recently completed a large retrospective real-world analysis that really looked at immunoglobulin testing practices as well as um, uh, IVIG or immunoglobulin replacement therapy practices across a large number of patients in the Mass General Brigham and Farber network, which really is comprised of many different clinical settings, including academic and community sites. This was really the first large real-world study to do this, and so the findings were interesting to us. And first, what we found was that in the real-world practice, testing for IgG levels is highly variable. Some people actually never undergo IgG testing, whereas others have this tested routinely. And the truth is that there are guidelines by various foundations and consensus bodies that define how we might approach this, but these are also highly variable, and it suggests that patients testing practices in IG, RT, or immunoglobulin replacement therapy use is perhaps variable, in part because we are lacking for a single consensus guidance for how to do this. We did find that when patients received immunoglobulin replacement therapy, that this was associated with reductions in infections, reductions in severe infections, and reductions in antimicrobial use associated with these infections. Really sort of highlighting that in the real-world setting that immunoglobulin replacement therapy is effective in reducing infection risk and antimicrobial use in selected patients. When I see a patient with CLL or a non-Hodgkin lymphoma histology, I do screen for low immunoglobulin levels at our initial meeting. I do this really routinely across the board. I don't do this because I'm going to always act on it, right? So if somebody's not having recurrent relevant infections, for example, recurrent or severe sinus, pulmonary or respiratory or skin or soft tissue infections, even in the presence of low immunoglobulin G levels, I don't initiate immunoglobulin replacement therapy because we do know that many patients go on to live without recurrent infections despite hypogammaglobulinemia. But I find it helpful to know this, and it's helpful for counseling my patients. I do monitor immunoglobulin levels intermittently in my patients, although again, I don't typically act on this in the absence of relevant infections. What I find that this is useful for is that it's useful for patient counseling, right? So if a patient knows that they're hypogammaglobulinemic, I find that they're more inclined to notify me if they're having infections because they know that this is something on their medical problem list. This was something we found in our study is what, in fact, and what we found was that if you looked at patients who had more frequent immunoglobulin levels checked over time, 3 or more versus less than 3 IgG levels evaluated, these patients actually had a lower risk of subsequently developing a severe infection, suggesting that maybe there's more awareness and these patients are reaching out to their doctors more frequently, or their doctors are just more privy to their immune dysfunction and maybe more likely to act if they hear of a minor infection and therefore maybe avoid a more severe infection. Now, this is a hypothesis. This is not something that we can, clearly draw a line between. But I think at a minimum really suggests that we should be more aware of this potential immune dysfunction in our patients. I think that the way that we approach IgG deficits in patients with CLL in particular, I find wanting, right? I mean, I think that it sounds a little crazy to patients to be told, you know that my IgG level is low, and I got a risk of severe infections from this, and yet you're not going to act until I have severe or recurrent infections. And it's this reactionary approach that actually allows patients to get sick before we intervene. Um, Now, the flip side is that if we were to intervene in all patients, we would be exposing a lot of patients who will never develop recurrent or severe infections to a treatment that requires a lot of visits and risks in and of itself, right? And so I think the opposite approach of intervening on everybody, irrespective of risk, in a sort of non-targeted way, is also, in my opinion, not appropriate. So I think we need to learn more about who's at risk. So we have a study here at the Mass General Cancer Center where what we're doing is we're using an assay that was developed by colleagues here that actually evaluates specific antibodies against a range of infections that are particularly relevant to our patients, including viral, bacterial, and fungal infections. And assesses not only are they present and what types of antibodies are present, but then are they actually able to initiate all the appropriate effector functions, sort of pull in other components of the immune system to clear and fight the infection. And so this is a study that is currently ongoing. We're about halfway done. We're enrolling 150 patients to this study and following these patients for 2 years after evaluating their immune function, their antibody functions, to see if they develop infections and what else happens with their CLL. And the goal is to then go back and develop really a functional assay, right? Like, so maybe some of these patients that have a low IgG level have actually very effective antibodies, and they're able to clear infections effectively. And maybe we can identify those with this assay. Contralateral, I mean, maybe we have patients who have an IgG level of 600 who we would not in general worry about, but they're having infections. We see this. Maybe we find that there's actual qualitative differences in these antibodies that we can detect that might predict who is or is not at risk for infection. And so this is the work that we're doing now that I hope might provide some additional sort of personalization to how we reduce infection risk in our patients.